Now, in the number of incorrect results reported, we have a lot of opportunity to affect that. That's the detection process, at least in the analytical phase. So eventually failure modes will occur. We in the laboratory have a lot of control over the likelihood that the affected results that are incorrect leave our laboratory. That's our domain, especially in the analytical phase. In the pre and post analytical phase, maybe not as much opportunity, but some. I mean, that's why we have things, the thing with pre and post analytical, they're usually failures that only affect a single specimen, and so you can't rely upon classic quality control strategies. But that's why we have things like delta checks and extreme checks and other kinds of consistency checks to try to identify specimen mix-ups and other kinds of pre-analytic stuff. And there are certain things we can try to do in the post-analytic phase too. But really, the place where we have a lot of opportunity is at the analytic phase. If we wanted to devote the resources and the effort to it, we could drive the number of incorrect results reported to zero. Might require running QCs with every patient sample and using very powerful techniques. Bio-Rad our salespeople will be happy to talk to you about that. But we have that control, right? That's the area we have the control. For the probability of harm from an incorrect result, again, we have very little opportunity to reduce risk there. Now, we certainly are all about trying to the best of our ability, inform and educate our clinical customers about how to make best use of the correct results that we're giving them, right? How to make good use of the correct results. And if we're doing a good job of that, coming along with that probably will provide them better opportunities to recognize when something doesn't quite look right, maybe identify an incorrect result and not allow it to lead to a misdiagnosis or incorrect action. But really, we have very little opportunity to try to reduce the likelihood that an incorrect result leads to patient harm that we report. So in summary, the laboratory has two main mechanisms to estimate and reduce the risk of patient harm. We can identify as many potential failure modes as possible and seek ways to reduce occurrences of those identified failure modes. And that's what EP23 talks about. We always have done that. It's really just trying to put some structure and formality to it, maybe. We can also implement QC strategies that minimize the number of incorrect patient results that are reported when that inevitable failure mode does occur. And that's statistical QC. That's what we have, what Jim and I have been publishing on and working on and thinking about for decades. And this combination enables a laboratory to address the full spectrum of patient risk implications for their operations. I kind of thought it was nice because the spectrum I used was the sequence of events that start with an initiating failure mode and end up with patient harm. And it started with some risk management principles. Right smack dab in the middle was statistical QC, and at the end was some risk management principles again. And Jim had a figure toward the very end of his talk that was vertical and had more to do with specimen, the life of a test result in the lab from pre-analytical to analytical to post-analytical. And he again had some risk management stuff at the pre-analytical phase, statistical QC right in the middle part, and then risk management at the end again. So the two together really fill out our needs in both of those ways. I'm 99% sure that I'm done. So I thank you very much for your time and attention.